Do I share this with them?
Okay, if you
Or
could
is it
all
okay?
take a seat, please. We're going to get started.
Okay.
So, welcome back to session 2. We're going to address challenges in governance for global health in the setting of fragile states. Before we begin, I just wanted to make a suggestion. I know that there are a number of people here who have had comments they would like to make that they haven't been able to offer because of time and the other constraints and circumstances. We'd like to suggest, Jeremy Farrar and I would like to suggest that if nothing else, you write down your thoughts and comments and consider sending them to one or both of us by email, and the addresses are right here. If there isn't time to air them in a public discussion, which we still hope to do, and we'll have plenty of time this afternoon to try to do that, but if we cannot, we will definitely incorporate, look at, listen to, and try to build on whatever you might like to send us. And you may feel that you have comments you'd rather send through this means rather than speaking publicly, and so please feel free to do that. Thank you. Dr. Tamori, the session is yours.
Thank you very much. You're welcome back from lunch. Sorry it was rushed, but these are fragile times. And we'll be talking about fragile governments in this session. We have two speakers, Paul Weiss and Mark Haywood. You can just join me over here. Paul is going to start this session. And Paul is from Stanford. Oh, I need to go there? Oh, okay, I can talk from here. Paul is from Stanford. He's a professor of pediatrics and health policy. He has a group that he's working with at Stanford. We deal with challenges and strengthening of health systems, especially in areas of political instability and weak government. So, Paul, the floor is yours.
Thanks so much, Dr. Tamori. I'd like to begin by just reviewing quickly the basic arguments for why this topic is necessary for the deliberations of this group and at this workshop. These basic arguments have been made in the reports and articles that have been circulated, as well as the presentation and many comments that took place earlier today. The first argument is basically that the global response to microbial threats will depend upon, in some significant way, on local health governance and capacity, that it's difficult to avoid this basic argument. Second is that the risk framework that's being discussed will have to confront the potential outbreaks that may, or in fact likely to occur in areas of political instability and weak governance. That certainly the Ebola catastrophe in West Africa involved this issue, and of course people made note of that several times already today. And the third issue is that the risk framework will need to improve community engagement, mobilization, and the messaging. And this has come up several times today as well. And the last is perhaps the most important for this group, is that the risk framework being discussed will need to be implemented in areas with extremely high levels of preventable deaths and illness. This provides the context for the whole discussion that's taking place here today, and that will ultimately define the Commission's deliberations. And to provide some context on this last point, I just want to show a slide of the countries with the highest neonatal mortality rates in the world. Neonatal mortality, kids who are born alive but die before 28 days of life, basically mortality the first month of life. it's a significant portion of young child mortality. I can show exactly the same table with young child mortality. But the important thing to notice is that every single one of these countries, except for one, has experienced significant civil conflict, war, political instability, and ongoing weak governance. That if we're talking about certainly maternal and child health, you cannot avoid this issue, that the majority of preventable deaths to children under 5 years of age in sub-Saharan Africa are taking place in countries that are politically unstable, have recently experienced civil conflict and war, and have weak governance. Now, in order to deal with this, in order to address these basic arguments, my suggestion is that we're going to have to come back to, in very many ways, what David Fidler suggested earlier, which is, in fact, the exercise of power. However, my suggestion is that it's not just the exercise of power in constructing the architecture of how WHO or other UN agencies relate to each other or to major funders around the world. That, in fact, the exercise of power will need to be played out on the ground in some of the poorest places on Earth. And because of that, we need to understand and address what the provision of public goods in areas of weak governance and civil conflict demands. And number one is the question of legitimacy. There's input legitimacy. In other words, and this has come up also today to a certain extent, is that in order to create policies that have real legitimacy, they must engage through procedures that are appropriate, the relevant stakeholders, the communities in question. In other words, it's procedural input, like a democratic process. However, there's a second mechanism of legitimacy, which is output, or performance legitimacy, where it really doesn't matter what procedures you've used to construct your strategies, as long as they really work. And there are governments around the world that have based themselves more on input legitimacy. Others have depended for their legitimacy on performance, on output, on impact. We also need to recognize the historical use of state coercion, that there are states with a high risk of witnessing or generating an outbreak that, in fact, are considered by political scientists who study this as predatory states. In other words, they do not have the interest of their populations at heart and basically operate rent-seeking and basically as a predatory government. What happens when you have weak legitimacy? The first is a loss of informational authority, that basically you get a kind of collapse of legitimacy authority such that you get delayed community mobilization. We have no authority to mobilize any community despite their capabilities or interests. The second is what a political scientist, James Scott, has called the art of not being governed. In fact, you get communities, populations that actively evade state authority because they view the central government as, in fact, predatory. And this came up pretty quickly in the Ebola outbreak by this tragic occurrence of health workers, journalists, and others who went out into the southeast corner of Guinea to mobilize communities, spread the word on Ebola, and were in fact attacked and 8 were killed. Now, it was represented in the press in Western countries primarily as these communities were ignorant or with superstition, but what really was not discussed and recognized was that in this part of Guinea, they had experienced 30 or 40 years of active war, primarily being assaulted by the central government and by the military and the police. That in fact, that their response to what they viewed as a central government activity was indeed to evade state authority rather than to respond the way that the health community would hope that they would respond. That their community institutions had been built up over 30 and 40 years to protect themselves from state authority. And this group of health workers and journalists and others basically walked into this situation. And what we must recognize is that when we talk about weak governance in many of these areas, we're not talking about weak communities. That in fact, we're talking about some of the most resourceful and resilient, strongest communities that exist on the planet. The problem is that groups like this and global health strategies have found it extremely difficult to cross the barriers that will generate the legitimacy that they need to engage the strengths of these communities. And when you have very weak legitimacy, loss of informational authority, you have active evasion, what happens is that public health gets turned over to state security apparatus, that the state authority to implement health strategies relies almost completely on coercion. And we saw this with the attempt to quarantine the community of West Point, community of 80,000 people in Monrovia, Liberia. And as you know, the quarantine had to be lifted after 10 days of a 21-day quarantine. That legitimacy is essential, and the requirements for this group are to understand the mechanisms to generate the legitimacy on the ground. A second component, a second concern is what we have generally called institutional design. That basically these are the formal procedures, accountability, the management. It's basically what the IHRs and this group has primarily been discussing and reading about is basically the institutional design of an appropriate response to preventing outbreaks. They also include, as has been discussed, formal relationships or mechanisms or architecture to engage non-state actors, including NGOs in many of these areas. And, of course, adequate resources. The third area, and an area that is particularly important to discuss in some detail, is the actual technical requirements of any kind of surveillance or active outbreak response. What, in fact, are the technical demands? And basically, you can begin to organize an analysis of what the requirements for working in these areas on the ground will look like by a very simple formulation presented in this graphic. But I want to call your attention to the technical characteristics, because it is very much part of the expertise of people in this room and also speaks to potential opportunities for concrete suggestions and recommendations that are different from what has been proposed in the past. Okay, how does the technical character relate to legitimacy? What do you need about this technical concern to make the health strategy a political strategy? First is there has to be general perception by the population of a real threat. The second is that you have to have the perception that you could do something about it. And third, that the provision of this technical strategy is considered responsibility of the state. And when you have these three components, these three requirements, basically you have transformed a technical intervention or set of technical interventions into political currency. That what you've done under certain conditions is a process of transformation with it, which what may appear to be intensely technical concerns on the ground has been transformed into political currency. And we see this in terms of creating a virtuous cycle. Good performance, you're getting people the technical intervention that's highly efficacious to respond to a perceived threat. That increases state legitimacy, which improves the capability of the health strategy to actually do what it's supposed to do. And you get this virtual cycle that's been identified empirically in a number of places, coming out of what began with a technical intervention. And you get actual explicit use of health interventions as political currency in counterinsurgency doctrine, that basically we're going to provide health services as a way of legitimizing the host government or a proxy for the host government. And it's important to recognize that this political currency, which is explicit in counterinsurgency doctrine, is related to, but may be distinct from, the use of military logistic capability, or what's been called here logistical assets. But we need to recognize that in this process of transformation from technical strategies into political currency, that it makes the health sector vulnerable to political assault. That this inherently is potentially a threat to the neutrality of health workers and health services in these environments. And we've seen this tragically take place most recently with polio eradication workers in Pakistan. However, we need to recognize that neutrality is not the same thing as being apolitical. That neutrality is an active process, and to be neutral demands a deep understanding of the local political dynamics. And so sometimes there's confusion or a kind of rebellion in the health world when we talk about the political currency, the reality of the political currency in the health sector in these situations, because of confusion between neutrality and being apolitical. There's no room to be apolitical here. We have to be smart about the politics. Now, what's the impact of these technical characteristics on the institutional governance requirements? Basically, the argument from our group is that each intervention places a distinct burden on governance, that immunizations place a different governance burden on the system than does reduction in maternal mortality, than will a surveillance and response system to a microbial outbreak. And because of this, that host governments or local governance is actually usually in these areas quite heterogeneous. It's important to note that one of the countries with the best record of reducing child mortality over the past 20 years was Liberia. At the same time, there was a significant failure to respond to Ebola. Why are kids immunized in Mogadishu? How are kids immunized in Mogadishu? How is polio being eradicated in northern Nigeria? That the governance burden of different health technologies are distinct. And because of that, our argument is that we can look at focused governance reform. One of the concerns, and in fact tends to be an exculpatory concern, is that we can't really fix security and governance in many of the areas we're most concerned about. We can't basically fix governance in the Eastern Congo, in Somalia, now parts of the Middle East and parts of Central America. And therefore, it's off limits. It's not doable. Our argument is that because governance capacity is heterogeneous and each intervention requires different things from governance, that you can create strategic governance reform depending on the technical requirements of each strategy that you are willing and able to implement. And because of this, our argument goes further and says that you will need to seek dual-use reforms that not only address the issues of surveillance for Ebola and response, but must, at some level, address local needs. that it would be peculiar, if not perverse, to try to implement governance reforms in places with extremely high young child and maternal mortality, with the governance reforms confined to outbreak surveillance and response that may or may not occur once every 20 years in these areas. There are moral questions, political questions, and our argument that they're actually implementation effectiveness arguments. So what are the requirements, particularly recommendations for the development of new knowledge in this arena? First, that we need a new set of integrated health and governance strategies, that we need combinations of diverse disciplines who have never spoken to each other, political science, global security, and health, maternal and child health, for example, in ways that we haven't done before. This has generally been viewed as the purview of complex humanitarian emergencies. Working in these areas has generally been confined to this area. That's insufficient. The length of stay in UNHCR camps is approaching 20 years. The bulk of the suffering, morbidity, and mortality associated with health problems in these areas does not take place in camps that are reachable by complex humanitarian emergency solutions. The second, we need to create a new taxonomy of strategic governance health interventions, that we can create new ways of thinking about a taxonomy of interventions that integrates the political with the technical. And here, once we are beginning to do that, you can begin to design for governance, not just for low cost or to have some technical capability, but to evade, overcome governance blockades. And third, we need to identify mechanisms by which global health governance reforms will reduce outbreak risk while also advancing local health priorities. I know many of you have deep experience in working in some of the areas that I'm discussing here. I can also not speak for leaders of ministries of health for the countries we're most concerned about. But my suggestion here is that the greatest danger to the workings and ultimate impact of this group and ultimately the Commission is not that you're going to recommend things that don't work for WHO or the IHRs, but that it will be perceived as aloof and disconnected from the reality on the ground. My suggestion is that as I thank my colleagues who have been instrumental in creating a new landscape of, if not understanding of analysis, is that by creating strategies that are effective, ultimately effective to address issues like Ebola, that it must also attend in the same time to the urgent current issues that plague most of these areas. It will be that kind of integrated approach, is my suggestion, that will best ensure that our policies, programs, and recommendations prove both effective and just. Thank you.
Thank you, Paul. You are indeed a wise man. We're going to have the next speaker, who has been avoiding me since he came, but he didn't realize that I knew that he grew up in Nigeria. Hi, Mark. Nice to see you.
Good afternoon.
Mark is in charge of the Section 27, which was established in 2010 for protecting human rights in South Africa. He had worked with Marxist workers' tendency. I'm just trying to let you know what to expect when he's talking. The floor is yours.
I wondered if you would spot that. That was many, many years ago. First of all, thank you very much for the opportunity to address this forum. I feel a little bit like a fish out of water. an activist amongst very, very distinguished scientists. But I hope that coming from the communities that we've referenced many times this morning, and as somebody involved on a day-to-day basis in trying to advocate for good health governance at local and national level in South Africa and in Southern Africa, that I might have some helpful reflections to present this afternoon. I think the first thing to say is I was asked to speak about an African perspective. And, you know, it doesn't need me to remind you that in Africa we have 11% of the global population, but 24% of the disease burden of the world. That in Africa we still have major challenges, including the major challenge of HIV. Perhaps I do need to remind you, because it hasn't been mentioned many times yet in this morning's discussions, that we still have an HIV epidemic in South Africa, which kills approximately 180,000 people per year. That is despite the fact that there are now up to 3 million people on antiretroviral treatment. We still have tuberculosis epidemic that kills 80,000 people, or at least 80,000 registered deaths per annum, and we have multi-drug resistant TB and XDR TB epidemics of sizes that are not, which we are not certain of. So the issue of health risk and the mitigation of health risk, and whether the strategies that we have are sufficient to the mitigation of health risk, is very much present in Africa and in Southern Africa, not just as a threat to others in other countries, but as a threat to others next door and in other neighborhoods. Now, I can understand that this process that you're involved in has been given greater urgency by Ebola. And I've heard a number of times this morning the issue of political will being raised as a critical issue. Is there the political will to tackle health risk? It reminds me of a few sentences, if I can work out how to change this. See? It reminds me of something I read in a book by Peter Peart fairly recently, his No Time to Lose, where he was describing the struggles in the early days before the identification of Ebola to get resources, to get healthcare workers, to get prioritization to that outbreak. And one day, Patin, whoever he may have been, Peter, said, "This is now a political priority." And so Peter thought, that's how it goes. Unless something is a political priority, figuring out how to save lives is not a big issue. And the question I think the forum needs to consider is mitigating and managing health risk a political priority? Because if it's not a political priority, then getting to the root causes rather than just managing the symptoms is not something that will happen. Ebola came to us as a shock, but actually it just reminds us of what we already knew. We knew that weak health systems failed to identify microbial threats. We knew that they even exacerbate it. We knew that epidemics then compound weak healthcare systems. None of that is new. The question that we have to struggle with is how do we break that vicious cycle? Now, as somebody who's observed these discussions from afar, it seems to me that we're not asking all the questions that need to be asked. We talk about Ebola, we talk about the absence of healthcare workers, the weakness of healthcare systems, but there are deeper questions that may be being avoided. And I would like to focus on two questions in particular. The first question that I think you need to consider is it possible that whilst we are seeing improved health outcomes in certain, in fact, many areas, whether it's infant mortality, is there a contradictory weakening of health systems taking place? And what is the implications of that? And the second is that we pay a lot of lip service to community mobilization. But what role actually is assigned to communities? How do we start speaking of communities as partners rather than looking at communities as victims? And in particular, what are the practical and political implications of community mobilization? What are the practical and political implications rather than just talk of community mobilization? Because I think there are implications in both regards. Now, I've been asked to provide this African perspective, and I want to elaborate now on both of those two questions. I would argue that what we are seeing in Africa at the moment is a weakening of many parts of health systems, that we need to start to rethink what we mean by health systems, not just in describing it, but what are the implications for the management of healthcare systems and for the management of disease. Now, I've identified 4 drivers, if you like, or determinants of weakening health systems, which I believe do have implications for health risk management. There may be additional drivers. The first is the weakening of public healthcare systems in the face of rapidly growing, exponentially growing private healthcare systems. In South Africa, private healthcare consumes the same amount of expenditure on 17% of the population as public healthcare expenditure spends on the other 83% of the population. Now, there's often a misunderstanding, particularly amongst consumers of healthcare, that private is good and public is bad, perhaps going to the issue of legitimacy raised by David. But what we see with private healthcare, and I'm not raising an ideological opposition, is that the quality of private healthcare does not match the quality of public healthcare. And particularly when it comes to issues like HIV, the quality is significantly worse than it is in the public healthcare sector. A recent study done by the International Finance Corporation says that the market for healthcare will double by 2016 to $35 billion. What is the implications? That is a private market for healthcare, which often works against the interests of the public provision and management of health. Over 50% of expenditure on health in sub-Saharan Africa is out-of-pocket expenditure, primarily going into private healthcare because of the poor quality of public healthcare systems when people are in situations of desperation and need. How do we address that and its implications on health systems going forward? How do we address the issue of corruption? Corruption is a major factor in the management of health systems at local, provincial, national, and global level. Again, to give you the facts that I'm most familiar with, in South Africa, we lose from the health system 20 billion rand, or approximately $2 billion per annum, out of the public and private healthcare system. At the moment in South Africa, our National Health Laboratory Services, which is obviously critical to the management of disease, to identification of risks collapse because of mismanagement, risks having to close laboratories on HIV and TB and so on because of mismanagement. How do we take cognizance of those real political issues as we have these discussions? The third issue that changes the game in many ways is the issue of migrancy and the mass movement of populations. I've been in England for the last 2 days and seen all the focus on the tragedy that is unfolding with migrants moving to Europe. But this mass migration that is taking place across Europe, of course, is nothing new. And in Africa, we have had a mass migration of people out of conflict zones and into other health jurisdictions that has been going on for years. In South Africa, for example, it's estimated that there are up to 2 million Zimbabwean migrants, undocumented migrants in South Africa, up to 2 million people. There's no budget for those 2 million migrants. There's no quantification of their health needs. And very often those migrants, because of their illegality, remain outside of the ambit of the healthcare system. What is the implications of that for risk mitigation? And the final point, which may not seem immediately to have anything to do with health systems, is the weakening of democracy and the closing of the political space for civil society. And when I hear people in this room talk about community mobilization and civil society, I understand, I hope, that there's a recognition that a key part of health governance is the organized voices of users of the healthcare system themselves. Users of healthcare systems have to form part of the governance system. But what we are experiencing is a closing down of that space. Over the past 3 years, more than 60 countries have drafted or passed laws that curtail NGO activity, including in the field of health. The political equation is changing. There's been some discussion about transparency and access to data and access to information. What is the implications of the changing political equation that sees the rise of powers like China and Russia and their influence over countries like Africa, and the beginning of the demise of Western powers with their emphasis on democracy and human rights and accountability and transparency? If we knock out civil society from the equation of health risk or health management or health frameworks, then the power to put anything in place, the power to obtain the type of legitimacy that David refers to, is greatly, greatly weakened. So again, what are the practical and political implications, if you agree with me on that argument? I want to finish just by saying a couple of points on AIDS. As I've listened to the discussions today, I've been, and the very justifiable analysis and deconstruction and unpacking of Ebola and what happened about Ebola, I've been asking myself, why are our memories so short? And where is the unpacking that needs to take place of what happened with the response to HIV? And what can we learn from the response to HIV, particularly when it comes to mobilized communities, setting agendas and driving responses and mitigating risks that we can carry into the risk framework more broadly? Now, that is a huge task, because in a sense it requires that you embrace a revolution, at least a social revolution that gives back to consumers and users of healthcare systems voices and agency and power over those systems, of which they have very little at this moment in time. But the difficult danger is that as we talk about AIDS, what is happening is that one area of advance is actually being significantly pushed back. That the organizations of patients, of communities, of people living with HIV that came up to shift the response to AIDS are now in the retreat and are no longer shaping the agenda. And I guess my appeal to you would be that we see H1N1, SARS, MERS, Ebola, HIV as part of a continuum, part of a continuum of vulnerability and risk, which requires a continuum of response and engagement as we try to build responses that are fit for purpose for the future. There's two tasks. The first task is the short-term tasks that have been discussed this morning, the putting into place of a risk framework, the finding of the resources, the agreement on the policies. But there's also the deeper societal tasks that require that we address not just the symptoms and wait for the next outbreak to address the symptoms, but that we get to the causes that are driving this vulnerability to an increasing level across the globe. Thank you very much.
Thank you, Mark, for talking like a true African. Incidentally, in his CV, he mentioned something about the influence of William Shakespeare on the politicians in South Africa. So you understand why they have that problem in South Africa. It was due to William Shakespeare, not any other person. We now have the two papers ready for comments and questions and discussions. We'll start from there. Yes, please. Yes. You want to? Okay. We'll start from the back row and then yes, sir. We take questions, maybe 3 or 4. I can see this.
Hello.
Anne-Marie, could you at least say your name so that our transcribers can get
Sure,
it?
sure. I'm Anne-Marie Kimball with Chatham House. I want to thank you for really some very insightful presentations. Having been at the Health Systems Accra workshop, the message that came through there very loud and clear, which was largely from in-region folk, was that the chronic problem behind the acute problem of Ebola was how do you get primary health care in very, very poor countries. And I know that's outside the scope of a risk framework as it's in an emergency situation, but to that group of folk, it was very central to the issue. And it was said, for example, what you have today is what you will have in an emergency, and when you have nothing, there will be nothing to work with. So I'd like to invite your thoughts, because having worked in emerging infections for probably more than 30 years, it's always the case that the first point of contact is your first detection. The first point of contact is the first place you could possibly design a strategy to mitigate emerging infections, and yet we continue to pretend that the lack of those systems somehow can be overcome by international command and control, which clearly is a fairly late intervention. So I would invite your comments, both from the academic analysis, which I thought was excellent, and then from your experience in South Africa. Thank you.
Are there any more on the back row there? Okay. Jeffrey?
Oh, okay. Thank you. Is the mic on? Yes. Yeah, thank you. Those are wonderful presentations. And in particular, I wanted to follow up on a couple of the comments that Dr. Wise made about strategic governance and integrated health and governance strategies and legitimacy, because I think they reflect much of what was discussed this morning and follow on very nicely. And it seems to me that if we're going to develop a strategy that effectively and practically recognizes the political power and interests in governance, we really need to understand that this entire landscape is very dynamic, and it's changing in the context of the political players, both governmental and non-governmental, and the context of the public health response that we might be addressing, and the type of response that's consequently needed. So I wanted to sort of get your thoughts on how one can develop a framework for governance that incorporates this tremendous potential for change in some of these very important components. On that same point, with respect to legitimacy, I wonder if we're doing ourselves a disservice by focusing only on infectious disease issues, because clearly we are going to be neglecting other important global health emergencies, and in the context of the IHR, of course, we talk about public health emergencies, not public health infectious disease emergencies. And then two other quick points on this. One is in the context of command and control. I'm wondering, which is very important at all levels, if there's something we can learn from our emergency management colleagues about multi-agency command and implementation of governance of emergency responses. I don't see many at the table here. And then the last issue is really around stakeholdering and legitimacy, and are we sure that we have the appropriate stakeholders at the table to assure that whatever recommendations we come up with will be acceptable. Henry mentioned the having 24 members on the H1N1 review committee turned out to be very beneficial because they had 24 members who already were familiar with and supported the guidance or the recommendations. And I'm just not saying that we don't, but I wanted to raise the issue of whether or not we do have the appropriate vetting of stakeholders. And of course, it was mentioned that we don't have many of our African colleagues here.
So I can see the tag there next to Patrick. Yeah.
My question is just what is the smallest and what is also the most effective level of resolution that you need in a community where there is weak governance to be able to either carry out surveillance or advance local health priorities? So if we were trying to develop a data network that collected data, but at the same time was the network through which other sort of approaches to changing health would flow, what's the optimal level to do that at? Is it at kind of a local regional level facilitated by civil society, or do you have to go so fine-grained you're going right down to trying to intervene at say the maternal health level, and everybody's born at some point, let's try and capture every single person at the point when they enter this planet? How do you find the optimal unit for spotting community trends in health and disseminating health information to a community in return?
At the back there, yeah.
Good afternoon, Kumran Rasanathan from UNICEF, and thanks for those very interesting presentations. I think you've touched on perhaps some of the most difficult issues that we face in this meeting related to the so-called deeper causes and determinants around governance and community engagement. The question I have for you is, based on your experience, it's a scope question. If we look at the experience when we look at health concerns in those deeper causes in society, we've had at best mixed success. I mean, to what extent do countries want health agencies, whether at global or national level, to address those issues of democratic deficits of governance, right? And that if we are going to do that, generally people want a quite specific practical list of measures that we're advocating, rather than a broad description of these very important things which tax not just health authorities, but all authorities across society. So as health agencies, we need to be humble in what our contribution can be. So I suppose just to summarize, the question is, in Sierra Leone in 2013, probably 40,000 children died before the age of 5. Now, most people would suggest that already constitutes a global health emergency. That is related not just to weaknesses in health systems, but weaknesses across societies. If, as the health sector, we struggle often to address those challenges in 2013, why do we feel that we somehow have something more to offer in 2015, given the Ebola experience? Thank you.
Over there. No. Can you answer when you said no?
I'm Mukesh Kapila, Professor of Global Health, Humanitarian Affairs at University of Manchester. I found the last intervention amongst all the other interventions all equally inspiring, but the last one was additionally refreshing. It made me reflect more widely. This morning I was getting somewhat depressed because the dominant paradigm appeared to be to look at governance through the lens of power, that governance was the exercising of power. And I couldn't but reflect from my experiences in 30 years working for the UN, the Red Cross, and WHO, that that's what's got us into the mess that we are in. That looking simply at governance as the exercising of power actually isn't going to take us anywhere at all. In fact, what we need to do is to give up power. And the more power you give up, the more influence you gain. And in the world, this is what Ebola really has taught us, the Ebola was a failure of trust, whether it was a trust in the local governments, whether it's trust in the international system, or whatever. And so surely a proper paradigm for global health governance would be about the amount of trust there is between the governed and the governors. And the idea that you can construct somehow a global health governance in a vacuum without linking it to national and local health governance is a bit like trying to build a house on sandy foundations. And yet quite a lot of our discussion seems to come from that background. So I don't think we're going to get anywhere with this conversation unless we revisit the basic paradigms and assumptions based on a changing world. Today, no one has the power to do anything. No one has a monopoly of knowledge, not even academics of science or World Health Organizations. And the problems are too big for anyone to do command and control. The world is in a rebellious mood. So to design a global governance system which depends on command and control and an assumption that everyone will follow because the chief governor says follow this one is, I think, is not in line with the mood of the world. What one needs is leadership based on passion, on values, basic public health, humanitarian values, and bringing the world together for a common cause, rather than a structured, systematic approach, which I'm afraid will be as outdated as soon as the lines on the organogram are done. That, I think, is a real legacy of Ebola and all the other failures, not just in the communicable diseases, but if you look at the other health crisis failures in other areas of humanitarian action.
Thank you. Are there other comments? Okay. Paul, would you like to start?
Sure. Thank you, Anne-Marie, for your comment and question. I'm a primary care kind of guy, and I spend most of my life focusing on primary care programs around the world. And of course, excellent, high-quality, accessible primary care should be a pragmatic goal, but also a question of justice, just a given. However, for the purposes of this group, there will be a requirement to confine recommendations and deliberations to that which is necessary for responding to the particular threat that this mandate really was all about. Therefore, the genius of the recommendations will be in constraint, in confinement, as opposed to comprehensive purview. The problem, of course, is that it actually has to work in the end. It has to be effective. And my argument that addressing the local priorities, the local needs, is not only a justice argument, it's a pragmatic argument. It is a requirement for the success of whatever recommendations are actually promulgated at the global level. However, all of primary care is not required to be successful in identifying and responding quickly to a microbial outbreak, in my view. That we can identify strategic governance requirements that would fit the confinement that this group requires, but yet also addresses the practicality on the ground of having capabilities that address local needs. I think we can definitely do that. This relates to to some of Jeffrey's comments, and I have a whole list, and I think they are all critical, and I'm going to try to respond to them as well. It is very much a dynamic landscape. The problem with the health world, in my view, is that it has tunnel vision. It looks at epidemiology and not political science. I'm an epidemiologist, so I get it, but I don't want to ever go to one of these areas and talk to some health person, sometimes very experienced health person, who just looked at the evaluation of a health program after 3 years and it failed miserably. And the evidence they suggest is it worked, but it was all political. I don't want to ever hear that again. Of course it's always political. And therefore we need to build that into the strategic dynamics of the intervention program, the health program from the beginning. Use technology to evade or overcome the governance burdens that we've identified. These are pragmatic but dynamic approaches in my view. Why only infectious diseases? I don't think it has to be confined to infectious disease, but what tends to stimulate argument and concern, particularly by OECD countries, are things that are sufficiently contagious to wind up in our country and cause a problem. And so anything that fits that bill, in my view, it doesn't have to be infectious, but have those characteristics, is likely to be in play in this area. The command and control capabilities and the lessons learned for emergency response, complex humanitarian emergency, I think are extremely informative, however insufficient. They are very good, for the most part, at acute response. But usually, within 2 weeks, they're out. Now, the military has been extremely good and very capable at looking at this for a more sustained way. But generally, complex humanitarian emergencies, they're looking at an acute situation, the camps are developed, and you respond. And as I mentioned, UNHCR camp is 20 years, is the average stay at this point. It's totally insufficient. We could build on and learn from those lessons. In terms of the stakeholders, I totally agree, and I expect that by the time the recommendations are put together here, that there will be more than adequate, appropriate representation of input. Dr. Gardy, you know, I do a lot of work with very detailed surveillance around the world, and I learn. I'm a very good listener, and I'm educable, and I'll take a lawyer's position on this. It depends, and it depends on what you're worried about. There are ingenious, elegant ways of using proxies or sentinel kinds of indicators that do not require community-based, every birth kinds of issues. We need to figure out what those are, much more so than we have, or using in terms of big data. I come from Silicon Valley, in ways that do not require the implementation of large new data collection systems. In terms of health agencies and how they speak to much broader issues of democracy and legitimacy, I actually think health agencies, not so much maybe, but health workers have spoken to this issue for several centuries and have always been out front in recognizing the requirements of legitimacy, and I would suggest trust, in ways that have made the health sector vulnerable at times, but also proud. And my suggestion is that we can do this, but we're going to need new vocabulary, new language, new metaphors to be able to do it better than we've done in a very dynamic world. I appreciate the comments that you made completely. However, I would just, in my view, it's always about the exercise of power. Whose power and how it is distributed and respected is a question of trust and deep legitimacy, the kind of deep legitimacy that goes beyond what we've been talking about. So I want to thank you for your comments and any correction to how I frame things.
Thank you, Mark.
Thanks. Yeah, just to respond on a couple of things. I think the question, Anne-Marie, about community healthcare workers in some ways illustrates part of what I've been trying to say. Because the issue of community healthcare workers has been obviously a programmatic issue in health for a very, very long time. We've talked about the importance of primary healthcare, community healthcare workers. In the response to HIV, a significant community healthcare workforce was built up to manage the death, to manage the illness, to provide home-based care, to begin to provide treatment, etc. That community healthcare workforce, that primary healthcare workforce, could have played a far wider role. A foundation was established. It could have been trained for other aspects of preventative care. It could have been trained for surveillance. But instead, what happens is when the threat recedes, as the HIV threat is perceived to have receded, the investment in that health workforce recedes, and that workforce disappears. So to give you the example of South Africa at the moment, you know, we counted something like 74,000, officially the Department of Health counted 74,000 community healthcare workers. They've decided that they can afford to integrate into the health system 40,000 of those 70-something thousand. 70-something thousand would have been insufficient anyway. There's still no policy. Those 40,000 people are earning on average 1,500 Rand a month, $100 a month. That's no basis for building effective health systems. And yet they can play a role in disease identification. I'll just give you one example. There's some scary information coming in South Africa at the moment in relation to what's happening with tuberculosis. And there's so little community knowledge, basic health literacy on disease and causes of disease, that several post-mortem studies of people who did not even go to hospital have found TB in 30% of those deaths, where people didn't even get as far as the hospital. So, you know, there's a critical role to be played in interrupting chains of disease, viral transmission, etc. But it's not getting the attention. We're not learning the lessons that we ought to learn. Which brings me to the point about, you know, again, to community mobilization. I think we all have to think differently about health. And one of the deep questions we have to ask is, how do we invoke the power and strengths of communities? Because as David said, and I noted it down, weak government doesn't mean weak communities. There's an intelligence in communities. And yet the voice of communities never finds itself, or rarely finds itself, in a meaningful policy-making space. Rarely finds itself. And there's a total disjuncture between what happens at a level like this and what happens, or what is understood, at community level. This might as well be happening on another planet, frankly, for what it means to the people with the real risks and the people with the real vulnerabilities. And how do you bridge that disjuncture? You know, where I come from, in the communities I work with, WHO means nothing. WHO may have a large country office. I don't know how big its country office is in South Africa, and I'm not making this as a criticism, small, but it means nothing to people. And yet, as was said this morning at some point, to whom is the WHO ultimately accountable? Is it to states, or is it to peoples? And it should be to peoples. And how can we bring the moral and political authority of the WHO back into play in relation to people's needs and in relation to people's risks. You know, it's very difficult to question what can they do to address democratic deficits. You have to tread on eggshells. Okay, I'm finished. I don't know the answer to that question, except to say that it does present you in a position where agencies like UNAIDS and PEPFAR, which may provide support to community organizations, sometimes find themselves having to do so in a context of supporting organizations that are politically unpopular in the country that they come from. Thanks.
Thank you very much. I see no more hands, so I think we're saving some time. Or just to, oh, sorry.
No, please go ahead. I think we'll need to move on to the next session,
okay.
Unfortunately.
Thank you. And so just to thank our presenters and also to say that as we push for democracy in Africa, in many countries, democracy divides down the line, down the family. And many times, if you're in the opposition, you don't even trust the government when it brings good health to your place. The only way around that has been to go back to the traditional society. And the rulers have been able to unite this together. We must remember that when we're dealing with some of these communities. Thank you very much.
Wonderful presentations. We hope to return to these points later in this workshop, but for now, we need to move into the next session. Dr. Chan, who is the first speaker, has a hard deadline at 4:30 or just before. So we will now turn to session 3, and Peggy Hamburg has kindly agreed to serve as moderator.
And should we invite the other panelists up now?
Sure.
Yeah. So if Dr. Chan, Cliff, hello. All right, well, this has been an incredible day, rich in discussion and expertise and important perspectives, and I think this session will continue in that mode. I know we do have to get back on schedule, so I will forego all of my words of wisdom on this topic. We have 4 terrific speakers, and we'll try to give each one 20 minutes, but if you want to speak shorter, feel free. And I will not do elaborate introductions of each speaker because you have that in your materials, and again, to save time, we want to have time for discussion. This session is called Challenges in Current Design of Global Health Governance, and of course, we've already begun the discussion on this important topic. We'll be able to dig more deeply in this session, and the goals are really to try to highlight ways that the WHO and member states can be better equipped to address global outbreaks, to talk about some of the recent proposals that have been made to enhance global preparedness and response, and to really identify how global security initiatives and frameworks can work together to boost preparedness and response, really the things we've been already talking about. And we are so fortunate to be able to begin our discussion of this important set of issues with Dr. Margaret Chan, who has given so graciously of her time to this overall global health risk initiative. I was with her in Hong Kong just a few weeks ago at the meeting that was focused on the research and development issues, and I think she's en route to China after this session, but she will be able now to provide us some really important perspective on really the view from WHO headquarters and from the ground 18 months after the outbreak was reported. Margaret?
Thank you, Peggy. No, I am very short, but can you all see me? Good. All right, let's go. First and foremost, let me thank Wellcome Trust for hosting this event, and happy birthday to Jeremy. No response? Okay. And then, of course, I wish to thank the IOM for organizing this workshop. Truly, an amazing experience, a very awesome meeting. Thank you for bringing together all these well-known experts, represent such a wide range of disciplines to share their experience, their thoughts. What I like is I like to become Mark Haywood now because he's a real activist. And many people say that Dr. Margaret Chan of WHO is an activist at heart. You will see the real activist today. Friends, colleagues, you know, I want to recognize so many of you in the audience, old friends, medium friends, and new friends. I don't know whether there's such thing called medium friends, but medium-term duration friends. Together, we need to explore every avenue for upgrading the world's outbreak preparedness and response capacities. Finish. Well, I've been asked to say something, and what I'll do is I will start by giving you an outline of the weaknesses and shortcomings revealed by the outbreak, an overview of some of the specific challenges all responders face, and a discussion of some successes as well as setbacks, at the risk of repeating what was actually referred to by some of my friends this morning, like David Heyman and, of course, Joanne Liu and, Professor Keiso Takimi. But as I always learn from my member states, important things are worth repeating. And I've been asked to speak about the view of WHO 18 months after the outbreak was reported in March of last year. Our views go back further to the events that followed the occurrence of the first case in a remote village in Guinea in December of 2013. The virus circulated for nearly 3 months, undetected, off every radar screen. Initially misdiagnosed as cholera, and then later thought to be Lassa fever, a viral hemorrhagic fever that is endemic in that part of Africa. In Liberia and Sierra Leone, the virus also circulated undetected for several weeks, gained a head start with explosive momentum. National and international responses ran behind the curve, ran behind the virus, and did not begin really to catch up until late October of last year. Friends, colleagues, this is the first point I want to make. No regime for global governance can manage the invisible. The first core capacity required to implement the international health regulation is an ability to detect events involving diseases or death above the expected levels of the particular time and place in all areas within the territory. But how can countries that routinely experience deaths from diseases like malaria, Lassa fever, yellow fever, typhoid fever, dengue, and cholera, just to name a few, recognize an unusual event in the midst of all these background noise from diseases with similar early symptoms? This is another fundamental problem that stands in the way of early detection and response. Ladies and gentlemen, this is the second point I want to make. The international health regulation have not performed as intended. A key objective when revising the IHR in 2005 was to move from a passive approach to a proactive approach that could detect an event early and contain it before it had a chance to spread internationally. That objective has, of course, a lot of support and was justified, as WHO and its partners had contained hundreds of outbreaks, also of Ebola, at source with little or no international spread for more than a decade. However, as we have learned, this proactive approach works only when countries have core capacities for early detection, timely notification, and response in place. And I want to underline the importance of timely notification in a transparent manner. The importance of having this capacity in place was well illustrated when Senegal, Nigeria, and Mali experienced their first imported cases. These governments caught the first case very quickly, launched an emergency response, and stopped onward transmission entirely, or held it to less than 20 cases. Recent expert groups convened by WHO have identified 3 weaknesses of the international health regulation. First, compliance with the obligation to build core capacities for event detection and response has been dismal. 8 years after the IHR came into force, fewer than a third of WHO member states meet the minimum requirements for core capacities to implement the IHR. So countries do not walk their talk. Second, many countries impose measures such as restrictions on travel and trade that went well beyond the temporary recommendations issued by the Emergency Committee last August. So you are punishing governments for being transparent. And if you are punished like that, what is the incentive to report early? The third weakness is the absence of a formal alert level of health risks other than the declaration of a public health emergency of international concern. Last week, ladies and gentlemen, I convened a review committee to assess the performance of the international health regulation during the Ebola outbreak and advise me on changes that need to happen, both immediately and longer term, through possible amendments to the IHR. This advice will feed into a number of reforms currently underway in WHO and, of course, endorsed by the memberships of the organization at the World Health Assembly this year. I am personally overseeing changes that include the establishment of a global health emergency workforce, referred to by many of you, building from bottom up from the countries themselves. And of course, a new emergency program with an operational platform that can shift into high gear quickly. Performance benchmarks that show exactly what is meant by high gear is important. And of course, the funding needed to make this happen. And David Nabarro, Dr. David Nabarro, is chairing an advisory group to capture the experience and wisdoms from different sectors and provide me with advice on the way forward. And I would encourage you to contact David Nabarro so that you can share with them your experiences, either from your organization or your personal experience. Friends, colleagues, looking back, the perception of the outbreak at WHO is that it is a steep uphill struggle with many barriers along the way. The challenges faced fall into 3 broad categories. First, absence of national detection and response capacities, which was referred to by many of you, at nearly every level of the health system, compounded by very poor transportation infrastructure and communication infrastructure. Second, the weak preparedness and response capacity within the international community, including extremely limited surge capacity. And third, the many tensions that arise between the sovereign right of nations to govern what happens in their territories and the need for solidarity and collective action against a shared threat. A disease like Ebola will expose every gap in health system capacity and exploit every opportunity opened by these gaps. At the start of the outbreak, the 3 countries who have gone through so many difficult times, post-war, post-conflict, many of you refer to it, only had 1 to 2 doctors per 100,000 population. Hospitals had no isolation ward, no culture of infection prevention and control, and frequently no electricity or running water. Systems for Ebola, for data collection, were rudimentary. Jennifer, responding to the point you make. rudimentary, fragmented, paper-driven, and designed for monthly, not daily reporting. Too late for emergency and response, outbreak response. And there was only one laboratory in the region equipped to diagnose viral hemorrhagic fevers. Waiting for a week or more for test results was the norm. Even after the arrival of many mobile labs, services were frequently overwhelmed. Backlogs in testing, in testing left many gaps as long as a week or more when the overall picture of the outbreak's evolution went blank. Hundreds of suspected and probable cases were never reported or tested. Populations, you mentioned about the mistrust of the population to the government. The mistrust to the health systems is starved, and they prefer to seek care from traditional healers rather than, the public health system, or including that, the private sector health system. And the community did not welcome teams of foreign responders, including WHO. And many of our colleagues, your partner, your institution, who come in space suits. And we really need to learn the culture. Road transportation, whether for transporting patients or specimens for diagnosis, was very primitive, greatly increasing the time needed to reach to treatment centers or to fare the laboratory samples and the results back and forth. Now, because of the severe shortage of treatment beds, Joanne, you talk about that, people suffering from common and treatable diseases like malaria, they were held together with very sick Ebola patients in crowded facilities, forced to wait for a week or more for diagnostic results. The risk of getting infected under such conditions was very high and very obvious. The international community was also poorly prepared. Though Ebola had been known for decades, no vaccine, no point-of-care diagnostic tests, or treatment beyond supportive care were available. As Ebola had previously been, a rare disease, expertise, especially in its management, was in short supply. All responders had trouble finding sufficient numbers of experienced clinicians and epidemiologists. Previously, no clinical teams, apart from those provided by MSF and some of the experts that go to African countries under the WHO umbrella called GOIN to provide support. So David, you know that very well in your times. So the expertise in managing Ebola truly is very scarce. And many agencies and organizations, in their great desire to help, they took on roles, functions that went well beyond their mandates and their previous experience. Those with no experience in the clinical management of Ebola took several months to become operational. And of course, thanks to many of you in the audience, MSF, CDC, and others, your experts have provided the training to prepare these clinicians who come from afar. For a time, I don't mind to tell you, for a time, MSF, WHO staff, Samaritan's Purse, and some brave teams from Uganda employed by WHO work on alone, shoulder to shoulder with the heroic health workers in the 3 countries. More than 500 of them lost their lives. Apart from the shortage of expertise that I referred to, one of the biggest barriers to staffing treatment centers was the absence of referral care for sick and possibly infected health workers. Medical evacuation by air was complicated for multiple reasons, and this difficulty actually deterred several countries from sending medical teams when they are in great need. As case incidents began to grow exponentially, no one could build Ebola treatment centers facilities fast enough. In September, Joanne, last year, MSF made the announcement that its capacity in Liberia were overwhelmed and began turning patients away. And this morning, you heard how painful it was for Joanne and her team to do so. No internationally agreed procedure were in place for coordinating the activities of the multiple response teams that eventually arrived. The problems created by the tensions between the rights of sovereign states and the need for global solidarity are likely to be the most difficult to address. Let me give you some examples that we in WHO encounter. A WHO going team was assembled, equipped, and ready to travel. The government refused to issue visas. Our efforts to quickly put WHO country offices on an emergency footing were frustrated by a government's insistence on reviewing and approving my hand-picked appointments. Some were initially refused, and this led to a loss of precious time. In another case, one government abruptly decided to report only confirmed cases and not suspected and probable cases as required by WHO. That decision, ladies and gentlemen, shut our eyes to what was really happening in the country. Much has been written about the extraordinary population mobility in the three countries. That's true. It is 7 times higher than other regions in Africa. People readily cross porous borders, but contact tracing teams do not. People need visas to cross borders. Many countries imposed traffic restrictions that isolated the three countries and vastly increased their hardship. Several airlines suspended flights to West Africa. This impeded the arrival of desperately needed response teams, equipment, and humanitarian aid. Let me remind you, it is not the Ministry of Health that takes the decision to seal a border, cancel visas, or prohibit an airplane carrying an Ebola patient from passing over its airspace or landing for refueling. As a final example, WHO advised against certain extreme control measures, as evidence strongly suggests they are not working. They are counterproductive. WHO can give advice, but we cannot interfere. No external authority can dictate what happens within a sovereign state, and you have heard the difficulties of this. So, ladies and gentlemen, one of the objectives of this workshop is to improve the resilience of the global health infrastructure to future outbreaks and emergency. In this context, a final observation may be helpful. We did indeed manage to climb that steep and slippery slope. Thank you to all of you for being such a good partner. Leadership, including command and control, by the presidents of the three countries was decisive. Community engagement was decisive. The distribution of messages and leaflets do not win hearts and minds and the cooperation of communities. It has to be genuine listening to the people, solving their problem, answering their questions, for them to see what is the benefit of these outside people coming to help us. You know, community engagement happens, and when community understand and own the problem and carve out their own socially and culturally acceptable solutions. We have seen that. We have seen that. When communities work out their way to separate the sick from the healthy, they own the solutions, they implemented it. That was far more effective than quarantines enforced by armed military personnel. With 32 laboratories deployed to the 3 countries and Nigeria, the speed and precision of diagnostic testing gradually approached that on offer in wealthy countries. Most lab results were able to, we get the results within 24 hours. That was not the case. Many people is asking the question, why do Africans have to wait for so long? Now, with the support of CDC, I want to thank, now who's the highest person? Rima, you represent Tom. With the support from CDC, WHO and others, data collection and reporting improved considerably, but it's still far from perfect. We need to continue to work harder on that front. Now, the number of treatment beds grew fairly rapidly, and because it was very clear that without that, we would not be able to get to where we are now today. And building treatment centers is not an easy task. Joanne, you have done that. You tried to build the biggest Ebola treatment center. WHO has also tried to build an Ebola treatment center, which is not our normal function and mandate, but the outpour of goodwill and commitment to support the countries on the ground is so great that we do everything that was not in our book. We built treatment centers in Liberia, and the WHO developed a prototype floor plan that maximized safety for patients and for care providers. And we are very happy that the World Plan was then used by the UK and the US military personnel to construct additional treatment centers. Now, to reduce some of the chaos of uncoordinated and sometimes inappropriate assistance, WHO also has learned. We have made an inventory of the qualifications and skills of foreign medical teams and developed a register as we are, moving with the Ebola, the evolution of the Ebola outbreak, so that the needs during the next outbreak can be matched with the most appropriate teams. And this time, we are going to save a lot of time. Ebola-specific specifications were developed for PPE, personal protective equipment. What we did was we brought together all the manufacturers that make PPE and also very experienced clinicians to select the best designs that offer maximum protection for the healthcare workers and yet allow clinicians to work in reasonably comfortable condition or environment under very hot and humid conditions. Ladies and gentlemen, the world is actually on the verge of having a safe and effective vaccine. And not only that, on that I want to thank the people of Guinea and the scientists in the country working with partners around the world. And WHO is very proud to be associated with this clinical trial to bring the evidence to be shared through the Lancet journal. And WHO has also pre-qualified for rapid point-of-care diagnostic tests. And we are now learning from the lessons of Ebola, developing a blueprint for R&D for future, a pandemic, for high-risk pathogens going forward. We will develop a generic clinical trial protocol and arrangements for fast-track regulatory approval and to expedite the development of new medical products during the next emergency. As we move into this final phase of tracking the last cases and breaking the last transmission chain, WHO deploy, for your information, nearly 1,000 staff to 68 field sites in the 3 countries. My member states keep reminding me, including some of the countries represented here, you are not an operational organization. I think the Ebola crisis has changed that perception. The outbreak is not yet over, but we are nearly there. All of these achievements were made possible by the unprecedented collaboration of multiple partners. As just one example, the laboratory WHO was able to mobilize involved collaboration with 19 institutions and partners in 2 major networks. At the same time, friends, colleagues, it is a humbling exercise to share with you my thoughts. As the head of WHO, I do not want this distinguished audience to leave with the impression that the WHO showed no leadership. This is certainly the impression created by the narrative in most media reports. Sitting there in that corner, I think the best reward I have today is to hear from Joanne New to say that WHO is a convenient scapegoat. Thank you, Joanne. And to hear from Professor Takemi saying similar comments. WHO, we have our shortcomings. I admit that. We could have done better. We fall short of the expectation of your governments. But let's be real, let's be honest. And together we must learn lessons. These changes that we have built in the last 18 to 24 months have created the conditions to make it possible to turn the curve, to turn the Ebola around and get to zero and maintain zero and help these countries to rebuild their health system, which is so important. Mark, you talk about the importance of integration. I fully agree with you, but today I'm not asked to talk about the importance of health system, but that is truly the centerpiece to help countries going forward. Managing the global regime for controlling the international spread of disease is a central and historical responsibility of WHO. We have much experience and many networks of collaborating laboratories and institutional partners that kicked in and worked well for well-known epidemic-prone diseases. However, let me qualify. These assets are insufficient. They are insufficient to manage a disease event that is unexpected, severe, and sustained, as Harvey Feinberg concluded when he was chairing the 2011 Review Committee under IHR. The world is ill-prepared for a severe and sustained influenza outbreak or similar outbreaks. As I said at the beginning, we need to explore together. Together is the word, the key word. Every avenue for upgrading the world's outbreak preparedness and response capacities. Let me make one final comment. Informal arrangements exist between WHO and the UN Secretary General for activating all the assets within the UN system to address an urgent health problem. Let me give you specific examples. The threat from H5N1 avian influenza, the 2009 influenza pandemic, and of course, the Ebola outbreak in West Africa. David Nabarro was called upon at my request by the Secretary General to coordinate all UN agencies in the event that the UN system need to kick in place to support. So please talk to David. He has ample experience to bring to bear how we can formalize this kind of arrangement, which is so necessary, but we need to identify the triggers. What kind of triggers do we need in order to make sure that the UN assets will move into place? We are talking about a response for a big, severe outbreak. We're not talking about the routine run-of-the-mill outbreaks. There are about 100 of them that WHO, with the support of US, CDC, and other partners, have been managing annually. So friends and colleagues, thank you so much for sharing your wisdom with us. And I look forward to seeing so many of you, formally and informally. And do not hesitate to send me an email with your advice, my email address is chan, C-H-A-N, m@who.int. So let me once again thank you.
Well, thank you very much, and I think that that has laid out a lot of issues and concerns that we will continue to be discussing the rest of this session and the rest of this meeting. Our next speaker will be Charles Clift, who is the Senior Consulting Fellow in the Center on Global Health Security at Chatham House here. And he, pre this recent Ebola outbreak, led an important working group at Chatham House on WHO and questions of organizational mission and reform. And I think he's going to be speaking with us today about that work and the report that came out of it under the rubric of form should follow function. What's the World Health Organization for?
Yes, I'd rather change the title, as you can
Okay.
see, to a rather more
Make it
simple
more
and
dignified.
direct, because I don't know who invented form should follow function, but I'm not quite sure I understood what it was. So what I wanted to do today was stick very much to the agenda which is set out for this session, so not go through all the report we did at Chatham House, because I've also, for my sins, been given another session tomorrow. So what I'm going to do this time round is I'm going to cover the background of the Chatham House report, but then concentrate on the agenda. So as an introduction, I should share with you the route by which I got to be invited here. In 2012, we established at Chatham House 2 high-level working groups, one looking at health financing and the other looking at health governance. Several people were involved in one or other of those groups. Probably one or two of you declined as well. And so some of you will be familiar with how they worked. They met 3 times in 2012 and 13. And their final reports were published in May last year during the World Health Assembly. So the governance group, which I was involved in, looked specifically at the role of WHO in the international system. It followed on from the internal WHO reform program, which Margaret Chan launched in 2010. To some, this might have seemed a duplication. Why do something else outside when this is being done already inside? I think the logic was that you can say things at Chatham House under the Chatham House rule that you can't necessarily say in the World Health Assembly. So you're able to talk a little more freely, and we thought that would draw people out and perhaps take the discussion a little beyond the more formal proceedings in the WHO. So we had lively discussions. There was consensus in a number of areas on the role that WHO should play. But there was very much less agreement concerning what sort of restructuring of WHO might or might not be desirable, or indeed possible. So in the end, we decided not to seek to attempt a consensus report, which might have meant watering down some of the more controversial proposals. And I then produced a report under my name, which nevertheless fairly reflects the deliberations of the working group, but not the recommendations I have to take responsibility for. So nobody else on the group or Chatham House was responsible for that. So this report was essentially completed in March 2014, well before the Ebola outbreak hit the headlines. So there was nothing, in fact, about, none of it was responding to Ebola because these events hadn't yet happened, or at least as far as we knew when we wrote it. But it was more about how WHO could reform more generally to deliver more effectively on its overall mandate. So following the launch of the report in 2014, for several months there wasn't much response until Ebola hit the headlines. And then I think people saw the connection between some of the recommendations in the report and what they perceived had gone wrong during the Ebola outbreak. In particular, both the reports about Ebola and our report focused on what might or might not be wrong with WHO's three-tier format. So I'm now going to concentrate on the agenda. Okay, so I want to seek to identify what functions we expect WHO to perform in a disease outbreak, and then to consider some of the parameters that should inform new arrangements to deal with outbreaks. So the WHO outlined in 2006 what it sees as its core functions. Which way do I go? This way? Oh. Nope. There. So these are the core functions which were developed in 2006, and they've been maintained in what they call the current program of work, which runs from 2014 to 19. So the point I would note about this is, where is the mention of what we're talking about today? And in fact, there is no mention in there of, if it's anywhere, it's in providing technical support, catalyzing change, and building capacity. And another set of things that came out of the reform program was WHO's leadership priorities. And that's better because you can see implementing the provisions of the IHR is one of WHO's 6 priorities. But that's very much focused on how do we help countries to meet the capacity provisions of the IHR, which, apart from not being so far very successful, doesn't also deal with what is WHO's role in a disease outbreak as such, as opposed to that of countries. So the very first recommendation we made in our report was that there should be some explicit recognition of WHO's core function. One of WHO's core functions should be promoting and maintaining global health security, which covers essentially not just WHO's work in disease outbreaks, but also preparedness, its role in relation to the IHR, and polio eradication. And it may be that that's not specific enough, but I was also aware that maintaining global health security can go well beyond this area of work. In fact, almost anything WHO does could be said to be about maintaining health security. So that's for consideration whether that is the right formulation. So what I want to do is to try and clarify what what are our expectations regarding WHO's role in an outbreak. So many, including general public or the press, think WHO should be running frontline operations to combat outbreaks. So this is a quote from an interview with Margaret Chan in September last year. So I think this is also the point that she was trying to get across just now. WHO has a limited role to help countries to deal with their own problems. So it's rather surprising that then she said, and we've been involved in designing and putting up treatment centers. Because in a way, that was what I thought. This is the line between what WHO should do and what it probably shouldn't do. It should coordinate others to do it. But then the point is, if nobody else is doing it, should WHO not step in? In which case, should it be a core function of WHO or not? So we yes. So there are varying expectations about WHO's role. I'm not sure if this is in the right order, but what confused me is the very different perspectives on WHO's role. So the first quote is from the WHO website, and Margaret Chan repeated some of those figures. There are 1,000 people deployed, and so on and so forth. And the second one's a very short one from a very long article by Laurie Garrett, which just, how do you reconcile those two views? That's my question. So I'm very much an amateur in this field. I'm an economist, not a doctor. I've never been dealing with a disease outbreak, but I've read a bit about it. So I don't want you to concentrate on each and every one of these, but I thought it's important to define what WHO should do. Somebody needs to define what are the boundaries of its work. Because unless we know what it should do and what it shouldn't do, it's very difficult to judge whether or not it failed or succeeded in what it was trying to do. And I feel a lot of the criticism of WHO is because of unrealistic expectations. And if we were therefore clear about what we expected of WHO, we could more easily also hold it to account for its success or failure or somewhere in between. So then I come to the kind of diagnosis we've been talking about today, and we'll talk about more. So this is from Barbara Stocking's first panel report, which says business as usual not an option, and we should look at the structural causes of any shortcomings. And this is from her second report, her panel's second report. So WHO does not currently possess the capacity or organizational culture to deliver a full emergency public health response, and so on. Nevertheless, it said WHO is the best option we have, and we should try to make it fit for purpose. This is another quote from our background documentation from Larry Gostin, who I don't see now, and Eric Friedman, who I don't think's here. So this is the kind of criticism that you saw, particularly in the press and in articles like this, about what had gone wrong at WHO. And again, it concentrates to some extent on, does the regional three-tier structure in WHO really work effectively in an emergency? This was referred to this morning, actually, from Harvey Feinberg's analysis of the H1N1. And again, he focused on this conflict, which Margaret Chan also mentioned, between the interests of member states and the possibly conflict with the interests of public health. And he also talks about the incoherence that can be introduced by the regional structure. So a premise underlying the solutions proposed by member states and many others, and I mentioned these very distinguished people. Angela Merkel at the World Health Assembly said, there's much to be said for the regional structure. On the other hand, it leads to a lot of problems during emergencies such as Ebola. Jeremy Farrow wrote an article in the New York Times, which is in your pack, which was fairly critical of WHO as well. Well, Wall Street Journal, in fact, I think. So that is why the buzzwords become command and control, and these are words we've heard several times today already, and I'm sure we'll hear more. And this is the essence of the report from Barbara Stocking. We should establish an organization in WHO, or possibly elsewhere, because there will be other models considered tomorrow, that can operate for brevity with military efficiency and speed as compared to the measured pace more suited to WHO's technical normative work. So I've had two particular issues, I think, arise out of that, which perhaps should form the basis for discussion. So my point is this analysis what actually went wrong right? So in a way, I'm questioning my own analysis because I've read a lot of stuff in the press, I've read articles, but I haven't really seen an objective analysis of, what did WHO do wrong? What was outside its control, what was within its control, but concerning what was within its control, what particularly did it do wrong? So the PHEIC declaration is often cited, but I don't think WHO fully accepts it made it too late, although I wait for a response. And the other issue is if there's 1,000 people on the ground, it's doing everything it could, but there are external constraints, since the absence of skilled people with the right skills. What did we expect WHO to do that it didn't? And what didn't it do that it should? So I don't think those questions have been satisfactorily answered to the extent that we could say the regional structure is what went wrong. That's why the Ebola response failed. I think it's more complicated than that. Okay. So then my other point was, if it is the right answer and command and control, can we be sure this will work in practical terms in WHO? Because most of the organization is decentralized and works in one way, and we're saying that we'll have another bit of the organization which works in a different way, and the two are somehow compatible. My question is that the case? You might find people in the organization who 1 minute are working for the regional director, and when there's an emergency are now working for somebody else. This is one of the recommendations in the Stocking report. So I think we need to consider how feasible is that as operationally, practically, and in terms of the way WHO politics and bureaucracy work. And Margaret Chan had a particular vision of command and control, which I was hoping she would be able to comment on and expand upon. And if she has time, maybe she will. So that seems to combine command and control with the existing structure in an interesting way. So I'd be interested to know how that works. And that is, I think I've been shorter than my time.
Indeed. Well, thank you very much. And shorter but full of substance, and raised a set of questions that I think we'll come back to as this session moves forward, and certainly as the overall meeting goes forward. I want to turn now to my friend and colleague, Colin McIff, who is the Senior Health Attaché in the U.S. mission in Geneva. And from that post, I know, because I worked in government with him until recently, he has handled a lot of very important health issues for the U.S. delegation, worked closely with WHO, and he's going to give a U.S. perspective on how WHO and the UN agencies can be more effective in responding to a public health emergency.
Thank you very much. Thanks, Peggy. Good afternoon, colleagues. It's really an honor to be here. I'm here in the first instance representing my boss back home, Ambassador Jimmy Kolker, who's the Assistant Secretary for Health and Human Services for Global Affairs. I also have an honor to be here because for the last maybe 10 months now, I've been able to co-chair with my counterpart from South Africa a group. Basically, it's been both the informal and formal negotiations around the Ebola crisis and what member states' response would be, and how we would help fulfill our governance responsibilities to WHO and where we want to go with WHO reform. And that process has continued as a so-called Friends of WHO Emergency Reform, and continues actually to this day. So I'll come to that in my remarks. I was asked to speak on U.S. government perspectives on ways to make the WHO and UN health governance system more effective and efficient during health emergencies. And so I would start by saying that as the United States, we stand behind our leadership in Geneva and around the world and support the relevant WHO Executive Board and World Health Assembly language, which reaffirms WHO as the global universal health agency that should lead and coordinate global response in infectious disease outbreaks and emergencies with health consequences. I think it's important to emphasize that our support and that of other governments is not unconditional. We believe really, and for a lot of the reasons that have been discussed this morning, this is really one of our last opportunities potentially to make WHO fit for purpose in the area of outbreaks and health emergencies before collectively the international community would feel compelled to seek solutions elsewhere. But at this moment, we stand behind Dr. Chan and the WHO team seeking to implement the reforms called for starting this past January. One thing I would urge this group to do, if you haven't already, and I know some have, but I think it is worth familiarizing yourself with two documents which are really kind of a pair. There's the EB Special Session Resolution from January 2015. It's EBSS3R1. It's only the third ever special session of the Executive Board, the first ever called during a public health emergency of international concern. And then the decision points that were follow-up from this last Health Assembly in May, WHA Decision 6810. Those are broad, very sweeping decisions that cover issues that we've talked about, including R&D, including health system strengthening. Since we're focused here in this session on emergency response, I'll focus on the mandates as we see it that what the Executive Board and the Assembly have provided to WHO. So as has been mentioned many times, the member states called for a single chain of command and control in emergencies across all three levels of the organization. And the fact that the Health Assembly and the Board called for this is an unusual step, given that there is this decentralized structure, regional structure that exists constitutionally in WHO. I think the second area to mention is the recognition of the unique aspects of WHO's emergency work, meaning that it requires specialized skills and approaches within the organization. As Dr. Clift has just talked about, different skill sets are required for emergency response than are required for day-to-day normative work. I think a third set of the mandates from the member states is the establishment of a small advisory group, which the DG announced in May and which the Health Assembly welcomed, which I think was an acknowledgement, we took as an acknowledgement of the need for expertise from outside of WHO and outside of the health sector, and also demonstrated DG Chan's commitment to make the changes needed within the organization. We endorsed and have further sought to strengthen the establishment of global health emergency workforce. This workforce will work under an all hazards approach, and I'll come back to that and what we mean and what we maybe don't mean, at least as the USG in terms of that. And then we have endorsed collectively the creation of a contingency fund to provide resources for WHO's initial response to outbreaks and emergencies with health consequences. For the USG, we agree with the analysis of the Stocking report that right now WHO doesn't have the capacity, the institutional systems, or the corporate culture to do this work. And so we think that this period that we are in right now will be one of our collective, an important collective opportunity to make the needed reforms within WHO and beyond to enable the organization and its partners to get it right. We don't think that this means that WHO should attempt to do everything or that many of the solutions didn't already exist before the West Africa Ebola outbreak. What we think WHO should be doing, for example, is the international team coordination and mobilization. For example, with respect to elements in the envisioned global health emergency workforce, which include GORN, a new robust platform for managing foreign medical teams, and WHO's role as health cluster lead in humanitarian response. We would say that the components of the workforce in our vision would retain their independence as all parts would not be mobilized in all instances. All emergencies do not require an infectious disease component, and all infectious disease outbreaks are not humanitarian emergencies. And so it's important to have these elements retain their distinctiveness while there is a single emergency management program with a stronger core. And so I think, for example, there would be a necessity to strengthen WHO's HQ capacity and core capacity through the regional offices and country teams. But it doesn't mean that again, everybody's going to do everything. It's just about making sure that there is that cadre of force ready to move and to help draw these linkages at an earlier time, and with, frankly, just the human capacity to do the work that's required of it. I think I'd like to underline a point that hasn't been talked about too much, but it's that it's another part that existed before the outbreak, the WHO's emergency response framework. We know this is being updated now, but I think one of the problems was that the emergency response framework was well known and accepted, as we understand it, for the humanitarian and emergency response people, but there wasn't a whole of agency approach, a collective understanding. So the infectious disease people didn't necessarily see that, the country teams didn't see it, country offices didn't see that, and the regional offices didn't see that. So I think making this a total part of WHO's work, I think, is going to be very critical. A few specific actions that we would like to talk about to see happen, and we know are in train, but we want to emphasize for this group. I think it's important that there be a creation of a structure containing all assets within outbreak preparedness and humanitarian response, as talked about, to deliver this unified all-hazard response, and that as we said, it includes this command and control structure through all levels of the organization. But if I could just break away for a moment, in speaking with my co-chair in the Friends group from South Africa, one of the things, I think there's a lot of unity, and I want to come to that in terms of the member states and in terms of the real political will that's there. But one of the things that does threaten to undermine that unity is indeed just exactly this question of what command and control means and how it will be implemented in WHO's decentralized structure. For a number of Western states, it means, hey, you need to do what you need to do, and you need to cut out the middle people and get what happened, what's needed done right at the time. But what has been said by a number of the African colleagues, and I think it's very important to take this into account, and especially recognizing that WHO is the organization that it is that what a number of colleagues have said is they want this command and control structure as well, and they want a clear, transparent, completely available to everyone understanding of what this command and control structure looks like and what this chain of command looks like. And they want to see the regional directors in that, not to cut out the regional offices, because the point has been made many times in Geneva that if you cut out the regional offices, what you're effectively saying is you're cutting out the countries where many of these emergencies and disasters are taking place. And so the regional offices need to be in that. But what the delegations have also said is they want to be able to hold their regional offices accountable. And so knowing exactly what the responsibilities are in that chain of command is a critical, I think, piece of that puzzle. I think one of the things also to emphasize for this group, and it's something that's a topic of conversation in Geneva, it's not a headline-grabbing thing, and it's not a very interesting thing, but some of the most important next steps in terms of creating this WHO reform are going to be exactly establishing these distinctive HR and IT systems within the organization, so that the emergency response teams can mobilize when they need to. And if that doesn't happen, then I think that will be that is, I think, one of the key factors on whether this reform will succeed or fail, frankly. And conscious of time and trying to cut things out a bit. Okay. Okay, thanks, Peggy. I think another theme from the executive board and WHA decisions that would be nice to, I think, for this group to think about, and that has come up a bit, is the need for the establishment of long-term and systematized relationships between WHO and the key partners, in particular in the broader UN system. So, for example, we understand that one of the contributing factors that helped to turn things around in the current outbreak was that ad hoc agreements were put in place between WHO and certain key partners, for example, WFP and UNICEF, to cover critical logistics and communication and community mobilization issues. those relationships and those MOUs exist only at this point in time for the current outbreak. What we'd like to see is that those relationships be made permanent and a long-term and systematized part of the reform, so that in the next crisis we're not trying to figure out where air bridges are going to come from, or who will develop a community mobilization strategy and how that will relate to the public health needs of that given emergency. So I think this is one of the things that we would really like to see. Another part of the ad hoc reforms for the emergency that we hope will lead, and I think was definitely from the early stages of the special session preparations, it's a very unusual thing in the special session resolution for the executive board to make recommendations to the Director General on her internal staffing situation, and we did make a request in that resolution, of course consulting with the Secretariat, for the establishment of a special representative with all the authorities needed to make all the changes needed within the organization to cover that. And of course that's been Special Representative Aylward. And I think that has had an effect to cut across the 3 clusters at the HQ to go through the regional offices. But we need to think about systematizing and making that more permanent as well, so that again the structure in place can have the authorities and the heft to get things done. With respect to the WHO relationships and the broader UN, we think that the Secretary General's Kikwete Commission will have a leading role to play in this. And we think that they can build from the commitments to reform from the Health Assembly this year and also the excellent analysis from the Stocking report to develop recommendations for how the broader UN system should be organized in health emergencies. For example, how will the proposed World Bank financing facility be deployed, and how can we access the SURF more readily? In terms of the contingency fund, I think it's important not to try to oversell that. I think the point of it is simply to have those resources for a very short-term needs, for immediate needs, to get response going, but that it would be only a bridge leading to the SURF. I think one of the things that has been interesting as a kind of a health diplomat and someone who's learned more about the humanitarian response world, and I've been in a number of meetings in this, definitely the U.S. government agrees with the analysis that has come from a number of quarters that the declaration of the FAIC was late. We do agree with that. But it's interesting that I think we on the health side did kind of fall into a bit of the trap, thinking that once the FAIC was declared, that somehow, okay, things are really going to start happening now. But of course, for the even just for the United States, it wasn't really until September 16th until the president really came on. So we had another 6 weeks for the U.S. to mobilize. I mean, obviously, there are many heroic efforts from CDC and USAID colleagues who had been on the ground throughout the crisis, absolutely. But in terms of the big-time mobilization, that only happened after. So I think one of the things that we would look to the Kikwete Commission, for example, as well, and I think the IHR Review Committee will also take this up, is what does it mean? First of all, do the health ministries themselves even understand what a FAIC means and what it doesn't mean? And then beyond that, prime minister's offices, finance ministries, are they going to take action? And can we organize the system not to replace leadership? I totally agree with those earlier comments, but to enable leadership to do its job. So I think I will stop there and just, I think, end with a little bit of a comment on political will. I think that's a huge point. I've been in my current position since 2010, and I've been doing multilateral negotiations for the U.S. for I guess about 18 years now. It's been an amazing opportunity to be a part of this particular effort. And I was there in the health assemblies, unfortunately, in 2012 and in 2014. In 2012, when we didn't do anything, unfortunately, to really mobilize on the Feinberg recommendations. And I think there was a lot of bickering among member states about the role of the private sector in the H1N1 crisis. There was, frankly, a lot of budget consciousness from donor governments, and not a really long view. But now we do have, I would say, sustained effort. The fact that there is this friends group in Geneva that has been meeting basically continuously now for 10 months, and we're still staying on this. And it's not just the United States and South Africa, it's been Cuba and China from the very beginning, the affected countries. Ambassador Yvette Stevens in Geneva from Sierra Leone, amazing lady, hugely helpful in mobilizing and continue to keep the Geneva community, which is not a community that focuses on things very long. She's been able to keep us focused, and I think that's been very helpful. And I think that what's also different, I think the points about following the money are very valid, but there is money now too. But before, when we've talked about IHRs in the Health Assembly, we say, you know, we're going to give a 2-year extension, and we really mean it this time. We're going to do it, but then we don't do it. This year, in the decision points of the Health Assembly, the 6810 decisions, the Health Assembly did specifically say that we've committed by 2019 to have full implementation of the IHRs in West and Central Africa and in other at-risk states. And then just weeks later, the G7 followed that up with the 60-country commitment. And then the U.S. has its billion plus in the 30 countries that we've committed for. Germany has just announced last week in Geneva, and I think we'll roll it out more substantively in September or at the UNGA. A health system strengthening initiative for Africa in the hundreds of millions of euro range. So there is serious money mobilizing, and we definitely have to take advantage of this moment, I think. And I think I'll stop there. Thanks, Peggy.
Okay, well, thank you very much. And throughout the day, we've been hearing references to the Stocking Report, and now we have the great good fortune to actually hear from Dame Barbara Stocking, who was the primary author of that report. As I understand it, she was appointed in March 2015 to chair the independent panel to assess WHO's response to the Ebola outbreak, and what must have been a heroic effort, published a final report in July of 2015, and she's going to speak to us now about the findings, conclusions, and recommendations of that report. And I just have to add that she brought to the role as chair of that group many, many years of experience responding to humanitarian crises as the director of Oxfam Great Britain, and probably equally important administrative skills in her current role as the president of Murray Edwards College. So thank you.
No, thank you all, and thank you very much for hearing me today, because it's a great opportunity to tell you as much as I can about the thinking as we went through. I should say, you thought it was pretty horrifying, the 4 months. I was even more horrified when Margaret Chan first phoned me and said, and we want a report for the World Health Assembly in May. But we managed to negotiate that it would be a progress report, but in fact, some of the findings were so obvious, actually, as we started working, that we were able, I think, to give a reasonably substantive report to the Health Assembly. And it is a great tribute to the member states that they did take it on very seriously then and really start moving straight away, which was really extremely helpful. Just to tell you about the panel, there were just 6 of us. If you like, there were 2 who were really expert in global governance, one of whom you'll hear again tomorrow, Ilona Kickbush, but also Julio Frank, of course, from Harvard School. There were 2 Africans who are expert in Ebola, Dr. Shaib, who ran the Nigeria response, and Jean-Jacques Mwembe, who's ran most responses in Africa, 25 or something in the DRC. And then 2 of us who you might say were coming from a more humanitarian emergency part, myself and Common Seater, and I won't try and present a second name, who was in the disaster team in the Philippines. So it was a nice mix of people. So what we did was we tried to meet as many people as we possibly can from all who are engaged in the whole Ebola response, not just WHO, but well beyond, including NGOs and so on, including communities when we got there. And we were able to visit the 3 most affected countries, and we did go to the Brazzaville regional office twice. But I don't claim that we've got to the bottom of everything in all of that, but I think some of the findings were so well understood, and there was so much consensus built up, as we've seen, around them. Now, I've got on 4 slides only all the recommendations in abbreviated form. I'm not going to speak to all of them, you'll be pleased to know. I'm going to spend a bit of time on this first one, though, the one labelled Global Health Security. And again, that is really starting right at the global level. And before, having just sat in a bit of the conversation before anybody thinks that I'm just talking about power at global level, you've got to remember I came from Oxfam, so I come from a sort of different place. But there is clearly a need for leadership at all sorts of different levels, from community to nation, up through international organisations and at the UN. And there is a big question here about, does global health security get as much discussion as it should when we're all talking about security at the global level? And so some of our recommendations we came to rather late on in a way was that we really have got to get much more high-level understanding and, if you like, monitoring of what the state of global health security is. And the obvious place for that is, of course, at the UN General Assembly, but also actually at the UN Security Council, because ultimately in this Ebola outbreak, the UN Security Council did get involved. And we can see the point that for very serious matters, like as happened in Ebola, it is really rather important that the UN Security Council has a role in making sure that the world is doing the things that it needs to do. And I think we're getting a bit of support for that. But there may be other routes that you can think of that gets global health security to that high level of oversight and attention. Not attention all of the time, but to be there so that it's on people's radar systems. We suggested in our report that there should be an annual global health security report. We actually suggested that it might be combined with a body that we recommended to actually have an independent body looking at the way WHO has and is going to develop its emergency health function. Those two things may not be the right things to put together. Again, that would be very interesting debate, and I know that the Secretary General's panel is having a look at that and thinking, okay, we see what the problem is, we're not getting that global attention, but what's the right way to do it? And most importantly, how do we get it well beyond ministries of health and, if you like, the health world that we all sit in and talk in? Because this is a matter, as Margaret Chan has said, this is a matter for heads of state, heads of government. It's those that take decisions ultimately about things like stopping flights of aircraft and all that. It's those that actually have ultimate responsibility and accountability for whether their countries have the core capacities to actually respond to what they're expected to do under IHR. So this is a bigger issue than ministries of health. Now, the first thing that we've suggested, I think you've talked about a bit, is the course. We need a proper plan for everybody getting to the core IHR capacities. It can't all be done at once. It's good what member states have said about Western Central Africa. What we said was, please would WHO take responsibility for pulling together a prioritised and costed plan. How can you move this along in a reasonable period of time? Where should you put your money first? How do we get the countries themselves to put their resources into this properly? And again, there's I think some discussion to be had about making it a real incentive for the countries to want to do this and invest in this. And in a way, that leads on to what might happen when you get to an outbreak or emergency phase, because it starts to reach the point where if you're starting to think about insurance mechanisms, for example, which the World Bank is, about whether you could put in more money into a country, both for its response, but also for the economic impacts of an outbreak. But of course, you would need to know what the basic state of their core capacities were and whether they had really used money that was available to them to make sure that that was really developed. So there's a lot of interconnection here about where incentives, particularly financial incentives, may fit in. But certainly we need a prioritised costed plan, and we also need to have the assessment done independently at country level, perhaps by peer review, could be independent experts. Only last week I was listening to the vets talking about this matter, and they seem to have cracked it rather better than on the human side of actually having a better sense of how prepared a country is for veterinary outbreaks, actually. So there's some learning to be done there. The second bit is about, this is a political question, it really is. How can we make sure that WHO has the ability to be our global citizen for us all, if you like, in making sure it can say what it needs to independently of what's going on with a particular disease or hazard and at what level in country. And we need to really work to strengthen WHO in that regard. And that, of course, brings me on to all the ones that say we want the review committee that's now sitting to have a look at these, because they're all about IHR. And frankly, for me, IHR is the biggest problem issue in all this. Why? Because it is a legal treaty that has no teeth in compliance at all. Now, so the question is, where do we take IHR from here? It's not, frankly, IHR is wonderful in many respects. You know, you read all the stuff and you say, yeah, core capacity is right, you know, loads of things, absolutely right. But if they can't be delivered, which they clearly can't, then we have a really very serious problem. So we began this, and we've only opened the doors on these things, I think, which is to think about the incentives for the countries themselves to be absolutely transparent about outbreaks, and what can you do with that. And as I say, there may be that, you know, some of those ideas about new financing mechanisms that you would have access to that would encourage people to come forward. But of course, we have to deal with the disincentives as well, which Margaret has described pretty strongly. And what can we do to stop countries doing the wrong things? And there are questions that we've raised about, well, actually, could you deal with it under the World Trade Organization, under non-tariff issues, for example? Where is it that there is somewhere you can put in some sanction into the system for what people do? This, of course, as you know very well, is highly, highly sensitive, because countries really believe that they are responsible for the health of their own people, and whatever they think that they should do, no matter whether that's well beyond what WHO thinks is necessary, they feel they have to do for their people. We haven't got to a point of shared sovereignty and understanding that you can do one thing one time, but it might be you the next time that's affected by what other people are doing to you. And we haven't built up, and that really is what global health security is, that multiple level acceptance that, in fact, we are also in each other's hands, that we have to have some compliance in the system that actually protects us all, protects everybody. And to me, fundamentally, that is the big problem of Ebola. I think we can crack a lot of the other problems, but that's the big one that's hanging there in the system that, you know, as Margaret described, made it so difficult, amongst other things, for WHO to get on and do its work. So that's the big question. So if you can just solve that one for us, that would be fine. Thank you. I wasn't going to say an awful lot about global health response, but given the sort of discussion that's going on, I think I'm going to say just a little bit more health emergency response. And this is really when we moved into the, okay, well, what did WHO do? And other agencies and, if you like, the global community, but the response part of all this. And of course, the first thing is, you know, we've said quite a lot of what we thought WHO could have done better, but we've always meant by WHO the Secretariat and the Member States, because you've got to remember, of course, that what WHO can do is actually at least quite strongly defined by what the Member States will allow it to do in priorities and also allow it to do in terms of financing. So there's a bit of we're all in this together again here. And there are two parts in the first two items there. Colin's talked about the contingency fund. But the fundamental issue is really for the member states. One is political will to accept that WHO should be responsible for a health emergency response. And basically, that's really what the World Health Assembly said in May. The bit it didn't say was that we're actually going to make sure that Margaret's got the money to do it. And that's a real worry. You know, because actually with the zero nominal growth, we looked at the actual the value of what you could buy now compared to 15 years ago. And basically on the core contributions, you know, you're down at 66% of purchasing power and so on. So it's gone down quite significantly. Now, if we're asking WHO to do something really rather substantially different, which I think we are, then how is it going to get the finances to do that? It's very odd that if we say it's very important, it doesn't come in its core, in the core contributions to what it's doing. And yet what we have at the moment is a WHO where its IHR outbreak capacities have been pruned back quite dramatically. And just to be absolutely clear, the emergency response bit is all funded from emergencies and not from core funding. Now, that's not a very good way to be prepared. You've got to have some core capacity in your emergency and outbreak area to really be prepared to do all the things that are being talked about. the work with partnering with other agencies, the work with partnering with the private sector, partnering with the NGOs. You know, how is all that work to be done outside an emergency time if you don't have any real core capacity? So that's why we were quite strong on this, both political will but actually funding question in here. But the question has come up. I mean, you're going to talk about it more tomorrow when Ilona will be with you. But there is this question about, well, is it WHO's job? That's, you know, really what Charles was raising. And just to put the arguments out to you as we saw them. First of all, what, if anything, is WHO's role if it is not actually the safeguarding of public health globally? So it seemed to us that philosophically, it's not to say that it had done it well, but philosophically, it feels like the place that you might put it. This is really its core business. So for us, this was truly a defining moment for WHO. It did not deliver what you would expect, but you can also say, well, but its member states did not expect it to deliver those things. You've seen the quotes and so on. But then if not WHO, who else would do this, and how would that happen? And we went through the arguments. We looked at some of the money that would take to set up a new agency, which we reckon is about $100 million to set up a new agency before it starts work. That's looking at the other UN agencies that have been set up. Just this is not random figures. This is actually looked, you know, a bit of research that was done. There's the time to set new agencies up, and then there's the fact that actually WHO does have all the technical knowledge that you would need actually in these emergencies. So you've then got a coordination function you have to make sure happens. And out of all that, so it's both, you know, philosophical, but also financial, but also very practical. It seemed to us that we should actually really give WHO a real chance and a push and support from member states to really make this happen, to actually make it capable of a health emergency response. Remembering, of course, already under the International Interagency Standing Committee at the UN, WHO is already the lead agency for health emergency response. It is expected to do that in emergencies, but of course what we haven't done is connected that up to outbreaks and infectious diseases. So that was why we came in and said those were the reasons that we thought WHO, it needs to change substantially, but it is the place that this should be done, and this is capable of being done. There's all sorts of arguments, well, maybe we'll go through them in more conversation, but, you know, for example, some of the arguments, you can't have a normative and an emergency function in the same organisation. Of course you can. Many organisations do that. You can have different sorts of organisations. I mean, I think of even my time in Oxfam, where we have a developmental function and we had a humanitarian function. And of course, they argued like mad all the time. But you run organisations like that. That's what good leadership and good management is all about, is to use people's different strengths at different times. And that's where I think the answers come into some of Charles's part about how you also shift an organisation into an emergency mode. You don't run at emergency all the time, but you have to have an organisation across the board that understands that that is part of the role of the organisation. And you have to have the rules of the game, including what exactly the regions do in that, at the time when you have to go into full steam, you know, proper emergency response. Now, I don't think that's too unknown. It's certainly not unknown amongst other UN agencies who are big on emergencies. It's not unknown under international NGOs that operate in that way. And frankly, it's not unknown in health services, because they often have to move from a day-to-day delivering into a real full-scale emergency response. And we know you have to shift what happens, you have to shift your who's accountable to whom, those sorts of responsibilities at those times. So that was a bit of an extra aside from me about, I do think that actually these things are doable. Leading organisations is about leading a lot of ambiguity, but taking charge and knowing when you're dealing with these different times, really. So we are very clear from the poll panel, this is, that WHO should now be given every support to get on and get this emergency health response team there. But as other people have said, we also think that it shouldn't operate on its own. Now, I think I'm going to skip to that and come back to one point just backwards afterwards. The reason that we say that we don't think WHO has to do all this all by itself is because there is a global humanitarian system that already operates. And there are agencies within that who can partner with WHO, and we've heard about them, WFP, UNICEF, and so on, but needs to be done in a proper, prepared, and partnered manner, i.e. in advance of the emergency. But WHO does sit at that level. The Interagency Standing Committee, for those of you who aren't familiar, has the principals of all UN agencies sitting on it and representatives of the bulk of the biggest NGOs engaged in humanitarian response. So you've got a body there that sits there. Sometimes it makes quite a mess when it all comes together on the ground. It doesn't work perfectly, but it is a system that is there and that you can use. And this is why we think that it's perfectly possible for WHO to actually be the responsible body for the health emergency response within that wider family, because that wider family is going to do quite a lot of the work, not only in the different agencies, but also actually through, for example, the both international and national NGOs that are the partners of each of those agencies too. So WHO's role becomes particularly one of coordination of that health emergency response, making sure it does all come together. And sometimes as part of that, being prepared to be actively operational. And that's most likely to be, of course, in areas of epidemiology, surveillance and so on, where it has its very own special, not only knowledge, but actually its on-call resources that it can bring in to do it. And also making sure that the foreign or even local, more local medical teams are available to move in. All of that requires an enormous amount of coordination, again, pre-working. But that's the central core role of WHO in what can happen in this. It doesn't require huge functions to be set up in Geneva. It requires more than there is now, but it doesn't, somebody cited to us, I think WFP has 8,500 staff. It doesn't need anything like that. We're talking in the probably, a few hundreds, I would think, maximum, that you're talking about it to actually run a global, health response. I don't know what the number is. Margaret's teams are working now on what it would take, what it does define. But this is not, turning into some other, massive other different agency. So we think that that can work perfectly well within that whole system. It will need not only the support of the other agencies, but also, as we put a bit there in where we mentioned the Secretary General, of course he did step in, and that's quite right that he did step in Ebola, because sometimes you will, again bringing it back up to that global health level, need the support above and beyond whatever WHO and all its partners can do to shift this to a higher level where you get the real political buy-in for what you need at the time. Now, I am going to go back one, because I am determined to mention one part of the things that that we think didn't go very well and that and we know needs to be worked on. And that is the third one down about community engagement. And interestingly, it was very clear to us quite a lot about what happened in community engagement once you get to the level of the country and into the communities themselves. If I compared some of what we heard from communities in Liberia compared to what was going on in Guinea, or for that matter, in some countries where we didn't visit, but I happen to know from my other previous life, something about what levels of community activity take place, it is very clear to see that actually one of your absolute essentials for delivery of any response like this is community ownership. No question whatsoever. And as I said, we saw it didn't happen at the beginning in Liberia, but ultimately as we got there by November, December, it was happening really very well in some of the communities at least. I don't know them all, I can't speak for them all. That wasn't the case in Guinea. Even as late as June, which is when I did my visit to Guinea, this June, it was very clear that there wasn't community ownership of what was going on in Ebola. It was very clear from two bits of evidence. One is that many new cases were and still are emerging who are not on contact tracers lists. That means that between either fallibility from the contact tracers or very much more likely that the community aren't actually giving the names of all their contacts, then that's why we don't know who they are. I reinforce that by the day before my visit. It was the day after when someone, a man who had died of Ebola, was put into a taxi to take him home with his two friends propped up on either side of the body to hold it in place in the back of a taxi. and sent him home, and it only emerged that this was going on when they went through one of the Ebola checkpoints and people got out of the car and it became clear that there was somebody dressed up, a dead body in the back. Now, if that's going on this June, that tells you that we have still not got there on community ownership. And that was the big difference in Liberia, of listening to the communities and them saying, once we got it, we took charge and we did this and we did that. And that's what you absolutely have to have. Now, my very last point on that is that also isn't something that happens in the middle of emergency. You can handle it better or worse in an emergency. You can send the right messages. You can be very sensitive to communities. You can try and understand what they're already doing and how they can adapt and try and persuade them. But my goodness, does it help if you've got some community development that's really serious? And I put this in because it was the end of that last bit of conversation that you had before. Community development can take place in all sorts of different ways. You can have community development because you've got, for example, groups of young people. For example, in some places, as in Sierra Leone, there's an enormous amount of work going on sexual health and HIV and AIDS. And actually a lot of young people, or volunteers from their own villages, were engaged. It's those sorts of people who are already known and respected, who you can mobilise in different ways, for example, in an Ebola response. Women's groups. It was so obvious in Guinea that there is very little community development that engages women at all. Yet in quite a lot of West Africa, you've got all sorts of, it's not that they're necessarily health projects, you've got economic empowerment projects, all sorts of things going on where women have got organised and come together. And as one anthropologist said to us, Ebola's like a fire. Women are the water and women will put out the fire. And that was a very interesting bit of insight into a Guinean man himself, into what's going on. Again, it's not just I suppose what I'm finishing with is it's not just the core capacities in terms of surveillance that matter in these countries, much though they're incredibly important. It is the fundamental level of development, especially community development, that is so critical if we're going to see our way through all these things. So that was what my panel came up with, and no doubt by the end of another year it'll be seen as complete rubbish, as these things are. But for the moment, let's have a good debate and see what you make of that. Thank you very much.
Well, thank you. All right. Well, thank you very much. And we did have, I think, 4 panelists, with real deep understanding of these issues and important perspectives put forward. We don't have much time before the scheduled break. Margaret needs to go. I would say, do you have 5 more minutes?
5 more minutes.
So if there are questions specifically to Margaret, I would say let's take advantage of her being here. We know she can talk fast, but please keep your questions short as well, so that we can take advantage. And if nobody has any questions, I'm sure she's happy to go. Oh, we do have questions.
Just a quick one. I know there's a lot of initiatives being undertaken by ECOWAS, the African Union, and AWAHO, and I wonder if you could sort of briefly describe WHO's relation to those other regional initiatives that are ongoing.
And let's get the other question asked, and then you'll do a masterful job. And Harvey has a question, too, answering with one answer all 3 of these questions.
It's just because I'm really struggling with one of the sentences that you've said, Margaret, and you just said that WHO cannot interfere. And so I'm having trouble with that, because if you cannot interfere and if you're not stepping up, because leadership at one point is a leader is going to step up to the plate and is going to get his foot wet. So if you're not willing to do that, what will happen? And then we can do any kind of reform, but if the general director doesn't feel that he can get his feet wet when it's the time to get them, then I'm afraid that it's going to be very difficult to move forward.
And just Harvey, before you respond.
This may be a slight variation on Joanne's question. Charles articulated a particular responsibility. He said the WHO should be responsible for promoting and maintaining global health security. My question to you is, do you accept that as a legitimate responsibility, especially if it may require taking operational responsibility for delivery of services on the ground in select circumstances?
Well, thank you for those very important questions. The first question is, ECOWAS, and this is a sub-regional group, that is working closely with WHO, and primarily, of course, leadership by the regional director herself, Dr. CD, and of course, she's taking the lead. Now, but when it comes to the whole organization, we know the capacity at the country level, at the regional level. I always say that you need to mobilize the assets of the entire organization. It's not just the regional taking the leadership. They can lead, but they sometimes need backstopping from head office. Or, in the case of Ebola, we learned it. We actually mobilized the other 5 regions that did not have Ebola, but to come in to work. So this is how we would like to move the organization forward. Instead of working as 7 organizations, we have to work as one. Now, I'd like to dovetail the 2 questions. Formally, my member states tell me that you cannot interfere because I'm a sovereign state. But I interfere. That's the bottom line. What did I do? I mean, when I told you about the 3 countries, Senegal, Nigeria, and of course, Mali, and the 3 countries hardest hit by Ebola, on a regular basis, I talk to the presidents. I have to intervene at that level. I don't know whether you call it interference or to put, I better be careful now, logic of, a leadership. I don't mind to tell you. On one occasion, I mobilized a laboratory to a country for an area that is hot, burning. And someone said to me, the government want to move it to another place because that is his constituency. I said, this was not my intention to mobilize the labs. I pick up the phone, talk to the president. I said, this cannot happen, okay? So now I do interfere, but I don't go on a microphone. I pick up the phone and tell the government, this is not acceptable. You have to honor your commitment. But my experience is, honestly, I talk about the informal sort of governance. Governments, leaders are actually very receptive if you pick up the phone and talk to them. One thing they cannot accept is name, blame, and shame them in public. It's not just the poor countries. The rich countries alike, the middle income countries too. Tell me which country would like to be named, blamed, and shamed? US? UK? No? Why should I name, blame, and shame the poor? No, I treat them all equal. I pick up the phone and I tell them, I expect you to do this. Now, I was told that I'm a very energetic Director General. It's good or bad, I don't want to critique myself. But this is a duty of the Director General. You need to be able to tell governments that they need to, first and foremost, take responsibility to take good care of their people. And number 2, be a good global citizen in solidarity, because you should not export your problems to other countries. So, Harvey, you happy with the answer? I agree with that. WHO's role is to promote the health, as Charles put it. The legitimacy, of course, in WHO is a member states organization. So that's why my comment earlier on this morning, that is 19th century, 20th century thinking, that countries alone can service the needs of their people. We need to open space for non-state actors, which include civil society and communities, academics, private sector. Of course, when I say private sector, some people get upset with me. And you know who you are, those countries. And open dialogue, transparency, and accountability. How can we hold governments to account? And this is the challenge.
But since Harvey may be too polite to ask the follow-up, what do you think about when and if WHO should have a hands-on operational on-the-ground role?
In fact, in many occasions, we mobilize and coordinate assets from around the world. I want to say that, you know, in this case, several countries have really put a lot of resources. The US, number one, and UK too, France and Germany, Japan and others, Cuba and China. Now, we coordinate all the responses. If you think that WHO can be the provider of last resort, we have done that in some instances, but that is not the normal sort of a business model we do. Right. But we only do that in the event that, you know, it's a absolutely failed state, very difficult to bring in people. But even then, we don't do it all by ourselves. We always get the support of civil society or governments.
So the notion of WHO coordinating an outbreak response team, what's your reaction to?
Coordinating
I mean, not coordinating, but, you know, the more direct logistical implementation of that.
But on the outbreak response, as I have explained, on an annual basis, we manage about 100 outbreaks. And we have been doing this for 70 years, right, David? And you only hear about Ebola. So what you did not hear, what happened to them? Because we coordinate, we bring in partners, we manage the outbreaks. Now, the Ebola is truly, in terms of its size, complexity, outstrip the capacity of WHO and outstrip the capacities of many organizations in this room. And I know that this is perhaps one of the biggest response that the US government has mounted, and like many other organizations. So when it goes to that size, we are talking about preparing the world better to deal with the worst crisis. And the worst crisis is going to be the next pandemic caused by a new and severe influenza virus. And we are not there yet. And Ebola is just a warm-up exercise. Ebola has not gone around the world. I think David Heyman's presentation was very clear. It has affected primarily 3 countries. And then 3 very high-income countries, UK, US, and Spain was the last one, and Senegal, Mali, and Nigeria, a total of 9 countries. And you can see already the complexity. With an influenza pandemic, even the mild one in 2009, it goes around the world in about 12 to 18 months. But can you imagine, going back to your conclusion, Harvey, the world is not well prepared for a big crisis of that magnitude. So I think this conversation is extremely important, and many other conversation that is happening. But we need to prepare because we know the next pandemic will come. It's not a matter if, it will come, but it's a matter of when.
Well, thank you. I said I'd keep you for another 5 minutes, and I'm afraid we went over, so hopefully.
Courtesy of Jeremy, and thank you for taking me to the airport. I hope I will not miss the flight. But let me thank the Wellcome Trust once again, but also, you know, David, you're representing Victor here and the IOM for bringing together such an awesome group of people and have a very frank exchange. Thank you.
Thank you.
Thank you, Dr. Chan. Before you all get up for a break, there's going to be a photo taken right now in the back of this room, and we would implore, ask, beg all of you to move back there for this photo. Then we will take a break, and we'll reconvene at 5 o'clock.